Good day, and welcome to Epstein, Becker & Green's webinar on OSHA's new enforcement initiative targeting inpatient healthcare facilities and nursing homes. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speaker will address your questions. You are also welcome to submit questions directly to the presenter following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein, Becker & Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Our speaker today will be Valerie Butera. Valerie is a member of the firm in the labor and employment practice in the Washington, D.C. office. At this time, I'd like to turn the webinar over to Valerie.
Thank you, Deb, and thank you for joining me today to talk about the details of OSHA's new enforcement initiative targeting inpatient healthcare and nursing homes. OSHA kicked off its increased scrutiny and enforcement efforts in healthcare by way of a memorandum from OSHA's Deputy Assistant Secretary, Dorothy Dougherty, to all OSHA regional administrators and state plans on June 25, 2015. The subject line of the memorandum simply reads, Inspection Guidance for Inpatient Healthcare Settings. The memorandum explains that this guidance applies to enforcement efforts in 2 North American industry classification system major groups, hospitals and nursing and residential care facilities. But the words you need to focus on here is groups. There are numerous types of healthcare and residential care facilities included in these 2 defined groups. For example, a hospital, for purposes of this initiative, is not just a general medical surgical hospital. It's also all of the facilities you see in the right-hand column of this slide and then some. And a nursing or residential care facility targeted for enforcement is a traditional nursing home or residential care facility, any of the facilities that you see on the left-hand side of this slide, and many more. As I'll explain in more detail in a moment, tuberculosis is one of the hazards that OSHA inspectors will be focusing on during the Inpatient Healthcare and Nursing Home Enforcement Initiative. Earlier this month, OSHA issued updated tuberculosis enforcement guidance, which, among other things, expanded the types of healthcare settings where OSHA enforcement should be taking place. A healthcare setting, for purposes of the tuberculosis enforcement guidance, is defined as any setting in which healthcare is delivered and workers might share airspace with persons with tuberculosis disease or come into contact with clinical tuberculosis specimens. The agency identified 3 categories of healthcare settings where tuberculosis hazards should be targeted. Inpatient settings, including but not limited to patient rooms, emergency departments, intensive care units, surgical suites, laboratories, laboratory procedure areas, sputum induction or inhalation respiratory therapy rooms, autopsy suites, and embalming rooms. Outpatient settings, such as tuberculosis treatment facilities, medical offices, ambulatory care settings, dialysis units, and dental care settings, and non-traditional facility-based settings like emergency medical service facilities, medical settings in correctional facilities, long-term care settings, drug treatment centers, and homeless shelters. For reasons that I'm about to explain, I believe that OSHA's inclusion of outpatient and non-traditional facility-based settings in the tuberculosis guidance has increased the likelihood that the heightened scrutiny called for in OSHA's inpatient enforcement initiative will eventually be applied to virtually the entire healthcare and nursing care industries. Turning back now to OSHA's inspection guidance for inpatient healthcare settings memorandum issued at the end of June, OSHA identified 7 specific hazards that compliance officers should be looking out for when conducting inspections under this initiative, which you see here. The first 5 hazards were the hazards focused on by OSHA in the recently concluded National Emphasis Program targeting nursing and residential care facilities. The last 2 are a couple of specific examples of other hazards that may be encountered in healthcare settings. Notably, the inspection guidance reminds compliance officers that when additional hazards, such as the last 2 hazards you see here, come to the attention of the compliance officer during an inspection, the scope of the inspection should be expanded to include those hazards. You need to be holistic and comprehensive when thinking about the types of hazards that may come to OSHA's attention. For example, have you ensured that the kitters you work with are using the safest types of scalpels and the surgical kits used at your facility? If not, you may be opening yourself up to a citation under the Bloodborne Pathogens standard. What about the hazards of the catheterization lab? OSHA's radiation standard was established before fluoroscopy even existed and is likely insufficient to protect doctors and nurses from the health hazards resulting from regularly being exposed to high levels of radiation, not to mention the MSDs caused by wearing heavy lead aprons day in and day out, which is currently the required cath lab PPE. Are your isolation gowns up to snuff? Just last week, the National Institute for Occupational Safety and Health published the results of a study on isolation gowns, second only to gloves as the most used piece of personal protective equipment in healthcare facilities, in which it tested 22 different gowns produced by various manufacturers and found nearly 1/3 of them insufficient to adequately protect healthcare workers from their job hazards. There are a number of ways to significantly reduce or eliminate these hazards that you may want to explore. The initial investment that you make in adopting safer tools and technologies now is highly likely to increase employee safety and morale, provide substantial savings by reducing your workers' compensation claims, and reduce or eliminate the possibility that you will receive an OSHA citation. A couple of practical points to remember here. Should you be inspected, you are well advised to ensure that the path you take the compliance officer for the walk-around inspection is as devoid of potential hazards as you can make it. But keep in mind that although this will improve the odds that additional hazards will not come to the attention of the compliance officer, employees may make a complaint to OSHA at any time, including during the inspection, and you may not retaliate against them for doing so. You need to do your level best to determine the hazards that exist in your workplace and to encourage open communications with your union reps or directly with employees in non-unionized facilities to identify potential hazards in your workplace and address them before OSHA comes calling, or you could be facing substantial citations. I also highly recommend conducting an attorney-client privileged health and safety audit of your workplace. I recommend the attorney-client privileged audit in which you will work with outside counsel to arrange the audit so that counsel can give you compliance advice based on the conclusions of the auditor, because this is the only way to ensure that your audit report is protected from disclosure to OSHA. Although the agency has a policy discouraging it, OSHA often requests your audit reports during its inspection and uses them as a guide for potential violations in your facility. I addressed auditing and how to prepare for an OSHA inspection in much more detail in the first webinar in this series. For your convenience, later in the webinar, we have included a slide providing you with the information you need to access the first webinar in this series in case you missed it and are interested in a more detailed explanation of these topics. Now, going back to that new tuberculosis guidance for a moment. Many people have asked me if I think that this inpatient enforcement initiative will spread to other types of healthcare and nursing care settings. I have always said yes, simply because employees and unions have become incredibly savvy when it comes to health and safety laws and whistleblower protections. So in my mind, once health and nursing care employees in a variety of settings hear about OSHA targeting health and nursing care, they're not going to hesitate to file an OSHA complaint if they're dissatisfied with their employer's commitment to health and safety. And I think OSHA, by specifically including outpatient and non-traditional facility-based settings in its enforcement, tuberculosis enforcement guidance, has increased its possibility even more. During TB inspections, healthcare employees in a variety of settings will sit down to talk with compliance officers about their employers' health and safety programs, providing yet another opportunity to complain to OSHA about their workplaces. And this comes on the heel of OSHA's reminding their inspectors that they should always expand their inspections when other hazards come to their attention during inspections. Each of these next few slides will just demonstrate for you the major reasons that OSHA chose to include these particular hazards in this initiative. I expect that MSDs will be a prime target for OSHA in this initiative, so you should be particularly diligent if you have a high reported number of injuries. OSHA recently published updated guidance for preventing workplace violence for healthcare and social service workers. This guide is extremely comprehensive and takes into account almost any conceivable healthcare setting and type of workplace violence incident. I highly recommend a careful study of these guidelines as they constitute a roadmap of what OSHA inspectors will be expecting to see in your workplace violence prevention programs. OSHA will be evaluating whether management is committed to the program and whether employees are involved in creating policy, whether employers have conducted an adequate hazard assessment in the workplace, whether employers have addressed identified hazards effectively, and whether the employer periodically evaluates whether the program can be improved. And of course, compliance officers will be focusing on whether employees are well trained on the policy and understand what to do in case of an emergency. Next, we turn to bloodborne pathogens. This one you're probably pretty familiar with. It's typically been the most frequently cited standard when it comes to healthcare. Tuberculosis and multi-drug resistant tuberculosis cases have been on the rise. In addition to the new OSHA enforcement guidance, OSHA, in conjunction with NIOSH, published its Hospital Respiratory Protection Program Toolkit in May 2015. This is another valuable guide for hospitals and nursing homes in fighting the spread of tuberculosis and other infectious diseases. Notably, the toolkit specifically states that merely complying with OSHA's existing respiratory protection standard is insufficient to avoid being cited. Rather, employers must follow the guidance in the toolkit and any additional relevant guidance related to controlling the spread of these diseases that the CDC or other public health agencies recommend. If you do not do so and are subject to an OSHA inspection, you will be cited. Next, we have slips, trips, and falls. Basically, OSHA is asking employers to have good housekeeping procedures in place and use common sense. Compliance officers will be looking for precautions such as those you see here. Turning to exposure to multi-drug resistant organisms. This is another problem that is occurring with increasing frequency and causing numerous work-related illnesses, hence its inclusion in the initiative. And then there is HAZCOM. Of course, hospital and nursing home employees are exposed to numerous chemicals in their work environment on any given workday, so OSHA included the standard in the initiative. OSHA cannot keep up with the rapidly changing workplace and the new hazards that crop up every day. In fact, the agency is notorious for taking years to pass new regulations. Luckily for OSHA, but unfortunately for employers, OSHA can rely upon the general duty clause when it wants to target a particular industry or type of hazard for which it does not yet have a standard, or where the agency has concluded that its existing standard is no longer sufficient to protect employees. Liberal use of the general duty clause in issuing citations is frowned upon, but OSHA under the Obama administration has used it more liberally than ever and makes no apologies for that. I advise clients that when it comes to safety, everyone should be treated equally. You need to be thinking about your temporary workers, contractors, and your own employees. OSHA has simply become too creative, and its confidence in issuing creative citations has become too powerful to ignore. It is entirely possible that OSHA can find a way to issue a citation to you now in ways we've never seen in the past. Just a few months ago, on March 18th, OSHA won a key victory for its policy favoring expansive use of the General Duty Clause when Walmart stores withdrew its long-standing legal challenge of an OSHA General Duty Clause citation arising from the tragic trampling death of a store employee during a Black Friday sales event in 2008. Walmart's decision could not have come at a better time for OSHA. The agency does not have standards in place for many of the hazards that it's heavily scrutinizing in its healthcare enforcement efforts. So what does OSHA tell its compliance officers with regards to inspection procedures for this initiative? Compliance officers are referred to the Field Operations Manual, which outlines the inspection procedures for any type of OSHA inspection. State plans must participate. It's important to remember here that the inspection guidance for inpatient healthcare settings was sent to state plans as well as regional federal OSHA offices, and that as the memorandum states, quote, because these hazards are nationwide, state plans are expected to follow the guidance provided in this memorandum, end quote. So don't let yourself be caught off guard thinking that you are off the hook simply because your workplace is in a state plan state. In fact, I would be particularly concerned and diligent in my efforts to come into compliance in states with aggressive state plans like California and Minnesota. The most remarkable thing to me about the inspection procedures is that OSHA will not just be using the General Duty Clause to cite hazards that are not yet regulated. It went so far as to provide sample General Duty Clause violation language in the inspection guidance memorandum for compliance officers to refer to when issuing general duty citations for musculoskeletal disorders, MRSA, and the like. Finally, compliance officers are encouraged to review thousands of pages of helpful documents, such as enforcement procedures, policies, and other guidance documents and websites. What concerns me about this is that healthcare is still relatively uncharted territory for OSHA compliance officers, and I have a hunch that they won't be interested in reading thousands of pages of guidance materials to get them up to speed. Plus, the compliance officers are so overloaded right now, they don't have time to read all of this even if they were so inclined. So you're very likely to be running into compliance officers who are undereducated and have been encouraged to liberally issue General Duty Clause citations. Should you find yourself on the receiving end of a citation under this initiative, I highly advise that you confer with counsel immediately. This combination of factors is likely to lead to a number of meritless citations. Any inspections of the broad group of workplaces that I mentioned earlier are subject to the inspection guidance for inpatient care settings. And as I mentioned earlier, I would not be at all surprised if this spread to outpatient and other healthcare settings as well. The initiative targets programmed and unprogrammed federal inspections, which I'll explain in more detail in a moment. OSHA has 10 regional offices, all of which have been encouraged to create regional or local emphasis programs after considering relevant information, such as the number of work sites in the region and whether the office has enough compliance officers available to conduct the inspections. I've been looking at this over the past several weeks. Just a few days ago, there were only five such programs, but still 5 out of 10 I thought was pretty impressive. As of this morning, we're up to 7 out of 10 regional offices have already launched local or regional emphasis programs targeting healthcare, and state plans have been encouraged to do the same. Often, OSHA selects employers to give it the potential for more bang for its buck. That is, employers with more than one facility. If OSHA finds that even one work site among a group of work sites owned by the same employer has a high rate of injuries or illnesses, it has directed compliance officers that inspections may be conducted at one or more of the employer's work sites. Often, the types of problems identified in an inspection of one facility are found at inspections of the employer's other work sites as well. OSHA can issue costly repeat citations to the employer by inspecting multiple facilities, finding similar issues throughout facilities, and issuing repeat citations at one facility based upon a similar citation having been issued at another of the employer's facilities. So if you find yourself dealing with an OSHA inspection at one facility and you have multiple other facilities, don't be surprised if OSHA shows up to inspect those other facilities as well. Not only does this allow OSHA to issue a greater number of citations to the employer, but it increases the penalties that it can demand. A violation, a violation classified as serious has a maximum penalty of $7,000, but a citation classified as repeat has a maximum penalty of $70,000. You may have heard about the dollar store citations. This is a perfect example. OSHA has inspected dollar stores around the country since 2009 and issued nearly 300 citations. As you've probably guessed, many of them have been repeat citations. Dollar Tree has now racked up total penalties of around $2 million. OSHA is always short on financial and physical resources, and has traditionally been expected to perform a certain number of inspections each year. In the past, compliance officers would often focus on inspecting construction and manufacturing facilities because such inspections are typically fairly quick and easy, resulting in many citations. In other words, enforcement was targeted on these industries because these inspections helped OSHA easily make its numbers. This focus on quick and easy inspections caused many highly hazardous industries to be relatively ignored. On average, a safety inspection takes 22 hours, a health inspection, 34. An ergonomics inspection, on the other hand, can literally take hundreds of hours. To address this problem, OSHA created the so-called weighted inspection system, which assigns points to inspections based on their complexity. Now compliance officers can be deployed to more complex inspections that are assigned to many more points, the more straightforward inspections that they used to do, and OSHA can evaluate performance based on these points instead of merely looking at the number of completed inspections. By rating the complexity of an inspection, OSHA intends to incentivize OSHA compliance officers and area officers to focus time and effort on more complex inspections that ultimately will have a greater impact on workplace safety and health. This year, OSHA has announced that it intends to use this program as a way to devote more resources to inspections involving two of the main targets of the healthcare initiative, musculoskeletal injuries and workplace violence. Unprogrammed inspections are generally prompted by an incident at the workplace resulting in a serious injury or fatality. The number of unprogrammed inspections is increasing dramatically because of OSHA's new electronic reporting rule. Under the rule, all employers must now report work-related fatalities within 8 hours, and all work-related inpatient hospitalizations, amputations, and losses of an eye within 24 hours. This change is significant for a number of reasons, not the least of which is that the Occupational Safety and Health Act has a 6-month statute of limitations. In the past, OSHA would not necessarily learn of some of these work-related injuries in time to dispatch a compliance officer to the work site for an inspection. Now OSHA is receiving information in real time and can immediately direct its compliance officers to the work sites where incidents have occurred. The new rule has had a significant immediate impact. About 40% of the injury and fatality incidents that have been reported in compliance with the rule have led to OSHA inspections. In addition to the inspections, OSHA has asked about 46% of the employers who have made reports to OSHA under the new rule to investigate such incidents themselves, to identify the root causes of the incident, and then report back to the agency what they have learned and their plans for addressing their findings. These root cause analyses are troubling as OSHA has not yet made clear whether it plans to use any information that an employer discovers in its root cause analysis and shares with OSHA as an admission should the agency decide to conduct an inspection and issue citations. Purportedly, OSHA intends to soon issue an official policy statement about whether it will use the information in these root cause analyses as admissions of violations. When asked what type of root cause analyses would be likely to lead to an OSHA inspection, the Deputy Director of Enforcement told me recently that inspections are more likely to result if the incident involves a potentially continuing hazard or if the agency finds that the employer's response was inadequate. And this would be a report that just blames the incident on the injured employee without explaining what happened and how the employer intends to ensure that it won't happen again. Many employers are required to keep logs of work-related injuries and illnesses. Traditionally, these logs have been hard copy documents that OSHA would only be likely to see or study if it visited a site for an inspection. Employers will soon be required to submit these records to OSHA electronically on a frequent basis. The data will be reviewed, compliance officers dispatched to inspect employers with high injury and illness rates, and the records will then be made publicly available on the Internet. OSHA will make employers' injury and illness information public through a website that will enable anyone to search employers' injury and illness records. The public will be able to search how many injuries and illnesses occurred at each workplace, the title of the affected employee, and the circumstances related to each incident. Because the circumstances of each incident will be included in the searchable data, it is entirely possible that the privacy rights of the affected employee and even the protected health information of a patient, if a patient happened to be involved in the incident, could be compromised. Although OSHA insists that private information will be scrubbed from the data before it's released to the public, it is yet to identify a means for doing so, nor has it established how it will accomplish this task when it's already lacking in both the physical and physical resources needed to do the job. Another concern for employers is the possibility of being painted as a bad actor, apathetic about employee health and safety, as the injury and illness reports do not provide the public with a full context of what happened. Finally, the public release of employers' injury and illness data will enable unions to easily identify employers with higher than average numbers of injuries and illnesses as targets for unionization. This new rule is expected to be released in September 2015. As I noted previously, OSHA referred its compliance officers to a mountain of references to look to in completing inspections at targeted facilities. I would certainly encourage you to explore these resources to the extent that you can. If nothing else, I would highly recommend that you at least page through the Field Operations Manual. It's pretty large in and of itself, but it's available for download on OSHA's website, and it walks you through what compliance officers should be doing during any inspection. The inspection guidance memorandum itself, also available on OSHA's website, provides some additional, very specific details of the steps compliance officers should take during inspections under this initiative. The most comprehensive guidance refers to musculoskeletal disorders, which is not surprising as OSHA has repeatedly identified this hazard as a prime target for enforcement efforts. Compliance officers are instructed to first determine the extent of patient or resident handling at the facility and to determine whether the facility has a problem by assessing the workplace incidence and severity rates and whether the workplace has implemented a process to address these hazards in an effective manner. Employers will be asked for the maximum census of patients or residents permitted and the current census during the inspection and the degree of ambulation of the patients and residents. Notably, compliance officers are to inspect all work areas where ergonomics issues may arise if there appear to be any problems in those areas, including offices, laundry rooms, and kitchens. Compliance officers will be looking for your ergonomics or safe patient handling program and evaluating multiple aspects of it. Is there a system for hazard identification and analysis? What are the credentials or experience of the person responsible for administering the program? Did employees have any say in developing the program? Is there a system for monitoring compliance and following up on deficiencies? They will also ask about your program implementation. How is patient-resident mobility determined, and how is the mobility determination communicated to the staff? Is the quantity and variety of appropriate lift, transfer, or reposition assistive devices available and adequate? Are there policies and procedures appropriate to eliminate and reduce exposure to manual lifting, transferring, or repositioning hazards at the workplace? Finally, compliance officers will hone in on your training. OSHA loves issuing citations for training, so I would pay particular attention to training in all aspects of your safety policy, but with regards to ergonomics, OSHA will be asking whether your employees have been trained on the recognition of ergonomic hazards associated with manual patient-resident lifting, transferring, or repositioning, whether they understand that they should report these injuries early, and the process for abating these hazards. Have your employees been trained in proper techniques and procedures to avoid exposure to ergonomic risk factors such that they can demonstrate competency in performing the lift, transfer, or repositioning task using the assistive device? You will want to have records of all of your employee training and ensure that your employees understood the training. Many employers require employees to pass quizzes on their training before they're permitted to do the work which required the training in the first place. I always think this is a good idea. If the employee does not pass the test the first time, let them take the training and test again. It's extremely helpful in defending a training citation to have documented evidence that the training took place and that your employees were able to demonstrate their comprehension. Finally, OSHA will determine if there is a recognized process to ensure that work-related MSDs are identified and treated early to prevent the development of a more serious condition. If you are targeted for a workplace violence inspection, the compliance officer should inform you of the reason of the inspection, including whether an incident prompted the investigation. Compliance officers will request information on any hazard assessments performed and incident reviews at the facilities concerning issues of workplace violence. At the opening conference, the compliance officer should identify all employees who are in charge of security and or responsible for the workplace violence prevention program if one exists. They will initially determine whether the employer has a workplace violence prevention program, and from there, you can expect your employees to be interviewed and a request for relevant documents to determine whether the employer has considered or implemented any protocols for worker protection against potential acts of violence, such as certain work practices or use of personal protective equipment. The compliance officer will evaluate whether your workplace violence prevention program takes sample safety programs into consideration and record keeping for injury and illness data. And this is what I was mentioning to you earlier. Be sure to check out the new guidance that just came out a couple of months ago. Other information likely to be reviewed includes medical records related to incidents of workplace violence, police incident reports, actions taken to prevent future incidents, and any other information related to the event. Compliance officers will also request information available regarding worker training programs and other methods used to inform workers of the potential for and prevention of workplace violence. When relevant, a compliance officer may also request any disciplinary records related to violence or aggression shown at the workplace. This is an area where we're already beginning to see enforcement efforts. Just last week, Minnesota State Plan launched an investigation of a brutal attack upon a counselor at a psychiatric hospital by one of the 16-year-old patients at the facility. Next, we come to tuberculosis inspections. Here, the compliance officer will want to see your written tuberculosis control plans. Such plans may include a TB infection control program, a respiratory protection plan, and a medical screening program. Employee interviews and observations are also to be expected in evaluating the written plans. The compliance officers will want to talk to whoever is in charge of your facility's infection control program and general employee health program. This can include a variety of employees, ranging from an occupational health director, a training director, facility engineer, director of nursing. Be sure that you have identified who that person is before OSHA has a chance to visit your work site, and inform them what to expect from an OSHA inspection in general and an OSHA inspection focused on tuberculosis in particular. Next, the compliance officer will determine whether a possible tuberculosis case has recently occurred at your facility. They'll do this through interviews of your staff and safety leaders and a review of available infection control data. They will contact the appropriate state or local health department to inquire whether your facility has reported any tuberculosis cases during the previous year, and will review your OSHA 300 logs for confirmed cases of work-related tuberculosis. If, after taking these steps, the compliance officer determines that there have not been any cases of tuberculosis, this portion of the inspection will end. If, however, the facility has had a suspected or confirmed TB case within the past 6 months, the compliance officer will proceed with a full tuberculosis-related inspection. This will consist of verifying that the employer's tuberculosis occupational exposure plan was implemented, which will be accomplished by way of employee interviews and direct observation if feasible. Compliance will be determined through review of facility plans for employee tuberculosis protection, employee interviews, and an inspection of appropriate areas of the facility. When looking for bloodborne pathogen hazards, the compliance officers should ask for any records that track bloodborne incidents. To evaluate compliance with the bloodborne pathogen standard, compliance officers will seek to establish the existence of hazards and determine the adequacy of work practices through employee interviews, and possibly observing any relevant practices if they can do so from a safe distance. In any event, photos or videos are normally not necessary, and in no event should identifiable photos be taken without the patient's consent. When it comes to slips, trips, and falls, compliance officers will be looking for obvious slip, trip, and fall hazards like the ones you see here, plus unguarded floor openings and holes, damaged or inadequate stairs and or stairways, elevated work surfaces which do not have standard guardrails, and inadequate aisles for moving residents. They will also be looking out for administrative and engineering controls used to prevent accidents on wet surfaces. These would include, but are not limited to, ensuring that spills are reported and immediately cleaned up, posting signs and barriers alerting employees to wet floors, keeping passages and aisles clear of clutter, and using appropriate footgear. Where appropriate, they will evaluate the use of no-skid waxes or other types of coated surfaces designed to enhance surface friction. OSHA has directed compliance officers to refer to the CDC's 2007 Guideline for Isolation Precautions, Preventing Transmission of Infectious Agents in Healthcare Settings, for guidance in inspecting a facility for multi-drug-resistant organisms. According to the CDC, facilities should be able to produce an infection control program that is based on local, state, or national recommendations, which includes, at a minimum, standards for hand hygiene, personal protective equipment, soiled patient care equipment, environmental control, textiles and laundry, needles and other sharps, patient resuscitation, patient placement, and respiratory hygiene. The facility should have enhanced contact precautions where there is evidence of an ongoing transmission, in settings with increased risk of transmission, and in areas where wounds cannot be contained by dressings. I could easily conduct an entire webinar on the topic of HAZCOM alone, so in the interest of time, I'm just going to hit the high points. OSHA just released its new inspection guidelines for the 2012 version of the Hazard Communication Standard last week. There is a tremendous focus on the written program and related HAZCOM documentation when it comes to enforcement. Among other things, it directs inspectors to review employers' written HAZCOM programs to determine whether they meet all of the requirements for the written program, whether they include details on labels and other forms of warning, information on safety data sheets, commonly known as SDSs, and information on training programs. Compliance officers should then confirm that what is written in the program document has been implemented in the workplace. The written program must address chemical inventory, which must have a product identifier for each chemical known to be present that aligns with the SDS and the label, and which can be used either for the entire facility or for individual work areas. The inventory must include all chemicals present in the facility, even if the chemicals are stored or not in use. The program must cover the methods the employer will use to inform employees of the hazards and non-routine tasks and hazards associated with chemicals contained in unlabeled pipes in their work areas. Programs for multi-employer work sites must include methods to provide all employers on-site access to SDSs for every hazardous chemical the other employees may be exposed to, methods to inform other employers about any necessary precautionary measures necessary to protect their employees, and how to inform other employers about the labeling system used. The written program must address its own availability to employees, employee representatives, NIOSH, and OSHA representatives upon request. The guidance further requires inspectors to ensure that programs address labels and other forms of warning, which should include designation of the persons responsible for labeling of shipped containers, designation of the persons responsible for workplace labeling, description of labeling systems used, descriptions of alternatives to labelings for workplace containers where applicable, and procedures to review and update label information when necessary. Written programs, according to the guidance, must also include designation of the persons responsible for obtaining and maintaining the SDS, how the data sheets are going to be maintained, procedures on how to retrieve SDSs electronically, including backup systems to be used in the event of a failure of the electronic equipment, and how employees are to access the SDSs. The programs must address procedures to follow if the SDS is not retrieved at the time of the first shipment, if it is suspected that the SDS is not appropriate, for example, it's missing necessary hazards, to determine if the SDS is current, and for chemical manufacturers or importers, procedures for updating the SDS when new and significant health information is identified. Programs must also address designation of the person responsible for conducting and training, how the training will be conducted, the required elements of the training program, procedures to train new employees at the time of their initial assignment, and to conduct refresher training when a new hazard is introduced into the workplace, and to train employees that are potentially exposed to chemicals used by other employers on multi-employer work sites. And the fun doesn't end there. Compliance officers are also to investigate chemicals found in your facility to determine whether the substances should be considered hazardous. Compliance officers are to carefully scrutinize any substance for which OSHA has established permissible exposure limits, any substance which the American Conference of Government Industrial Hygienists has established a threshold limit value in the latest edition of its annual list and documentation of threshold limit values, and any substance which the National Toxicology Program has found to be a suspect or confirmed carcinogen, or which OSHA regulates as a carcinogen. Epstein Becker Green releases numerous communications as a means to keep you informed, and here are several examples. If you are not receiving our e-communications and would like to receive future issues, please contact our office. To keep apprised of up-to-the-minute developments in occupational safety, employment, healthcare, and the intersection of these areas, subscribe to Epstein Becker Green's OSHA Law Update blog, Health, Employment, and Labor blog, and Health Law Advisor blog. Reach out if there's a topic you want to learn about, and we are happy to either send you a blog we've already written or we will write on the topic for you. Here is a site where you can access the first webinar in this series, and again, you'll receive this webinar in your email in a few days, and you can easily just click on this and navigate your way there. And now, if we have any questions, we have a few minutes.
We have a question. What kind of audit is OSHA going to conduct to see if we are in compliance with TB?
For tuberculosis. That's where they're going to be going in and looking at your respiratory protection. You should also have a tuberculosis control plan in place. They're going to talk to your employees and find out, what their impressions are of the policy and whether it's being implemented. They're going to talk to your employees and find out whether they have been trained on tuberculosis control and whether they understood the training, how often you're trained, things of that nature. They will also probably look at your OSHA 300 logs to determine if you've had any work-related cases regarding that have resulted in tuberculosis. They're also free to contact state regulators to determine whether there have been any tuberculosis outbreaks in your facility.
Okay, another question we have is, do you know the 7 regions that develop their own emphasis criteria?
I did not write them down off the top of my head, but I am happy to provide that to you by email after the webinar.
Next, where do ambulance services fall under target areas?
Right now, they're not in the target areas, but that's one of those areas where I think that it could reach, the employment initiative, the enforcement initiative could eventually reach other types of services, and at some point, I think it could trickle down to ambulatory. The tuberculosis, to the extent that tuberculosis inspections are happening that are focused solely on tuberculosis, that does apply to ambulatory settings. But right now, they're not covered by the entire program.
Okay. Are outpatient clinics exempt from 300 log requirements if they are considered SIC code 804, offices of other healthcare practitioners, and have less than 10 employees at the clinic?
My initial answer to that is no, but I would like to just double check that because that's sort of a complicated question that involves looking at a couple different things. So I will, again, follow up with you on my specific definite answer to that, but my initial impression is no, I don't think so.
Thank you. If we are identified as a low-risk medical provider by the DOH and we do not treat tuberculosis, would this still apply? It would depend on, whether any of the other, whether you have a high rate of injuries and illnesses and any of the other kind of targeted hazards. So say you had a high level of MSDs, but you're otherwise considered a low-risk medical provider, you could still be inspected if you're an inpatient facility and, qualify in some other way. How is the calculation for rates and risks done? OSHA mentions a per 10,000 worker month.
Yes. Gosh, I'm getting all the very difficult questions today. That's another one that I can definitely answer for you, but it would take about 15 minutes, so I promise to get back to you today and explain that to you.
Okay. Has the electronic reporting for hospitalizations gone live yet?
Electronic reporting, it applies to for everyone, yes, and for including hospitalizations. All employers and all inpatient hospitalizations, and it began January 1st, 2015.
Okay. Have the Dollar Tree penalties been paid also? Is there a likelihood of criminal sanctions?
That I couldn't tell you. I don't represent Dollar Tree. I'm not going to say anything more than that, but so I have no idea whether they pay their penalties. And the criminal sanctions thing is controversial right now. A lot of people are criticizing OSHA for not pursuing criminal sanctions more often. What they seem to be doing is letting states prosecute. So that's a really question that's very much up in the air at this point.
Okay. How about home health or target areas?
For home health, for target areas, right now, that's not so much, well, there's one or two different kinds of facilities that fall into that category, some of which are on the slide at the beginning, but it's generally, I mean, we're talking about like halfway houses that have nursing provided 24/7, things of that nature. It's actually kind of a strange compilation of things.
Anything on regional specific targets as well?
And again, I will just, if you could just take down names for me, I'll get back to you on what those 7 targets regions are.
Okay. If surgeons reject a safety scalpel. That was,
yeah, I know.
How is it based on the primary performance of the device? Will a citation be issued?
Okay, I would imagine not. I mean, as long as you can demonstrate to OSHA that you chose the scalpel that you thought was, you thought provided the greatest degree of safety for your employees, that's generally what OSHA is concerned about. But obviously, you have concerns about your patients as well. But I can't imagine, it would be difficult for me to imagine OSHA giving a citation under those circumstances.
And lastly, are there any data repository vendors recommendations that would help an organization be compliant?
Let's see. I mean, there are definitely consultants out there. Otherwise, it's kind of hard to say. You can get some indication of information from the Bureau of Labor and Statistics website, but that's awfully difficult to navigate if you don't really know what you're doing. So it's kind of difficult for me to answer that one.
Okay, one more. Do employees also have to be involved in choosing the safety devices used in clinics?
No, there's no rule on that, but employers are supposed to be, at least the bloodborne pathogen standard specifically requires employers to evaluate whether the tools that they choose are the safest. But that, in any event, that's an employer's responsibility, not the employees, and it doesn't necessarily apply to other hazards in the inpatient facility either.
How does HIPAA apply when an OSHA inspector wants to review medical records in relation to WPV?
There is an entire, there's actually an entire guidance document on that. So that's yet another good question with a long answer, and I will be happy to follow up with you afterwards on that and get that document to you. I think that was the last question. Thank you, Valerie, and thank you all for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein, Becker, and Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.